So, good morning. I'm Dr. Alessandro Galluzzi from Italy, and today I will speak about the vertical dimension of occlusion with analog and digital flow. So, let's start from what the patient asked to us. The patient asked a beautiful smile, but for the patient, a beautiful smile is just to have straight and white teeth. So, my question is that enough? Do we have something, a code, a protocol to make a beautiful smile? So it's very easy to get it. It's very easy. We just have to respect some geometric form, and we can have we can give in an easy way a beautiful smile to our patient. But there is a way to make happy our patient, a method, a protocol better than the other. Well, my question is no. So I will share to you my protocol to make happy my patient. My answer is no. So let's see this patient. They are my patients. So what to do to this patient? We see the different option. What to do? So first option is to do nothing. For example, we just put the teeth and we don't see that there is a problem. We don't see that there is a problem. Okay, I don't know the problem and I do nothing to solve it. Or nothing, I see that there is a problem, but I don't know how to solve it. So I do nothing. Or that's the most common situation where I know that there is a problem and I pass the problem to the lab. I say them, please increase the vertical dimension about 2 millimeters, 3 millimeters. Another option is that is very difficult. They teach us something to make to increase the vertical dimension, but it's very complicated. So we do nothing. So let's see how I treat my patient. Because when I see the patient, I want to make this way that is very it's normal. People became old, they lose the first molar, etc. I want to always to reverse this process. And I have a protocol, a method. If you see all these patients, they are the same person, but they look better after the treatment with me. Everybody, they look better. It's not just question of a beautiful smile. There is something more. There is something more. So it's enough to put these white and straight teeth, or there is something more. We have to see the face. We have to go a little bit more far away from what we used to see, means the teeth. And if you see some patient before and after, they look better. Also, when they even don't show us how they smile. Yes, of course, after they smile, everybody look better. Everybody look better. So I will show you a very interesting protocol to increase the vertical dimension to make this change in analog and digital way. Everybody are better after the treatment. So let's start from here. Our import. What difference there is between left and right? Nothing. But when I show you the lower middle third, well, change everything. Change everything. So do we have the rules? Do we have the rules? But well, here I didn't have rules on that time. I just asked to my lab to increase the vertical dimension to 3 millimeters. And how much risk we get doing this changing. We need a protocol, and that's what I will show you. Okay, we need rules. The lack of rules is destabilizing. So that is a way to increase the vertical dimension. And in Italy, we don't use it very much, but it's very common. In some part of the world, they call it big multifunctional. Or there is an academy, the ROA, in Central and South America. Or there are these two Brazilian, Milene and Renato, then they teach and they make webinar in all the world about this protocol, okay? And also, we see Lucas Lassman also proposed something similar. I learned it from my professor, and it's something a little bit more. So I call it vertical dimension functional, because we make a jig, some aesthetic and phonetic test, and also some posturological test. I learned it from my professor, Sandro Prati. So why we have to just not check the vertical dimension, but also the jaw position? Because if you see this patient, everybody, they lose vertical dimension, but someone have the jaw go in the front, sometimes in the front of the left. It's not that, like an elevator. The jaw doesn't go just up. He can move in the space. So the two reference we have to see is the jaw position and the vertical dimension of occlusion, JP and VDO. But why restore it? It's just aesthetic? It's just aesthetic? No, it's not only aesthetic. Because when we make in competition, we put in competition muscle versus teeth, and teeth is implants, etc., prosthesis. Well, who wins are the muscle. Lose vertical dimension, give a muscle tone increase and increase of intensity. When we restore vertical dimension and jaw position, we will obtain ideal muscle tone and the reduction of intensity. This is physiology, but just see this patient. I will ask them, please smile. The most easy things we can ask to a patient. This is before and after. Look how the muscle look more relaxed. From the neck, I just increase the vertical dimension. Everybody look better before, not just the smile. All the system, the chewing system, is more relaxed. So how does vertical dimension functional work? Well, the philosophy is the myocentric. The position, the reference position we will obtain in, from the muscle of the patient. There is a lot. If we go to see in the history of the dentistry, and the myocentric jaw position determined by the muscle without manual control. If you see also in the last 2 months, everybody speak about neuromuscular dentistry, in what therapeutic position should the jaw be fixed during the restoration, repositioning of the jaw and changing the vertical dimension. That is what we are looking. This is the trend, what the dentistry are studying now. So we see how we can obtain the jaw position, the vertical dimension at the same time. We will reconstruct, we composite the 1.1 and 4.1, the upper and lower incisor, okay? In this way, with composite, no bonding, etc. That's the standard dimension of the teeth of a patient, but if you think this is the medium dimension, and we start from here, it's the same in all the world. So we reconstruct the two incisors, central incisor. Then we have to customize it, the sides, in this way, with aesthetic and phonetic test. The aesthetic is the A and the E. A is dental exposure at resting position, and E is for aesthetic. We will see how longer the patient will show his smile at the end of the treatment. Then phoneme analysis with F, we know the margins, incisor position, and lip with the lip, and the S during works with S and Z, the patient have not to feel the contact between the two incisors. Well, after customizing the dimension of the two incisor, we will obtain what? We'll obtain a jig, and the jig will work like will deprogram. We relax the muscle of the patient, means the jaw will start to repositioning on the three-dimensional plane. So we obtain the contact like this, and this is a jig. How you can be sure that the muscle of the patient are relaxing? Because the patient, in the drum test, the muscle of the patient doesn't have to, we don't have to force it, have to be natural. And we have to listen this ting, 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 ting. This is like a drum. That's because we call it drum test. In this way. Well, in the moment when the muscle will be relaxed, the jaw will start to move it, to change the position like the muscle wants. We will fix it, but before we have to make this at the best of the aesthetic and phonetic test. Putting composite, removing composite, something like that. Something like that. Wait. Something, I don't know. Okay, something like that. Must be very easy, quick. Okay. And then after we will block the position, we will obtain the space and we will give to the lab. So let's see some patient in analogic. This girl has a big problem. We will remove all the teeth, but not the central incisor and this molar that they was without problem. We will reconstruct this, these two incisor like we want to save it. After we will remove it, we will make our aesthetic and phonetic test, and we will fix it in this case with the VAX, and in 2 sessions we will arrive from here to these results. Also, we will see how to treat the removable prosthesis going to the fixed prosthesis. So she wants a new prosthesis. She already has a removable prosthesis in the lower and 3 teeth or 4 teeth in the upper jaw. So in the same way, I increase the 11 and 41. I search the neuromuscular position. I take this position and I give it to the lab. We also have some palatal veneers and 2 new removable prostheses. But here, who wins is the myocentric at the right vertical dimension. And the results is in 2 sessions like this. We arrive very quick. We obtain very quick. But one day arrived to me this man without any the removable prosthesis. So how can we obtain the 11 and 41? Well, we take an impression, and I ask the lab to make acrylic, like Invisalign, something like that, very easy. And then I see the middle, and in the middle I put with Duralay 2 removable prosthesis T, like 11 and 41. I fix them with some cookie dent. I don't know how to call it. It's the glue for the removable prosthesis. And I make my aesthetic and phonetic test. This is the first session. In the first session, you see how I adjust the 2 incisor. I obtain the jig at the right vertical dimension. I fix and I give to the lab. In the second session, I will try the first 6 incisors, and then if everything is okay, I finalize the patient. Same, no teeth, no removable prosthesis. So I take an impression, acrylic mask, like how I can say, like Invisalign. The lab fix me 2 teeth. I fix it in the mouth of the patient, and then I block it with some Occlufast or any kind of silicone. I give it to the lab. Then we make the second session. I try the smile of the patient, and if everything is okay, I go very easy to give the final prosthesis to the patient. Same, always the same. Patient doesn't have teeth, the 2 acrylic mask. I make my aesthetic and phonetic test. I search the right vertical dimension and the myocentric, the position of the jaw, the three-dimensional position of the jaw. And I adjust everything. You see, this is the jig. I fix it and I give it to the lab. We try the smile of the patient in this way. Everything is okay, so we can arrive to the final prosthesis. Somebody asked me, but doctor, but maybe this patient born in the skeleton 3 3rd class. Well, how to understand this? Easy. You have to ask to the patient some photo when they was young, in this way. So I am sure that I have to make a repositioning to this patient, and I did it. 1 month ago, another colleagues know that I do this, ask me, you must help me with this patient. How? You see, how can I do? And I say, but are you sure that this patient, this is not his natural, this is an aesthetic problem? And so I ask him, make a picture to him and ask him a picture when he was young. And so very easy, we understand that this patient born in 3rd class. So yes, he lose vertical dimension, but I will not change his natural equilibrium. It's impossible to ask to the lab make a wax up. How the lab will make a wax up, and how we will understand how these two how the patient of the mouth have to close. Even the patient doesn't know how to close the mouth. It's impossible to make a wax up. I want something from the patient to give it the best, and then we make. You see, I already asked, like always, the picture when he photo. I ask him a photo. Always the same. Always the same. Always the same. 1141, and we obtain great results. Also, this old woman. Yes, but this is old woman. So we must give her the best we can, and the best we can is asking a picture when they was young, understand that they lose vertical dimension, finding the right vertical dimension and the right myocentric, and give them. You see, we make the test, and we obtain easy, great, beautiful smile, but macro aesthetic of the face. This way. Example, this woman come to me. She lose all the teeth. And so what to do? This bridge stay there from 30 years. I will not remove the bridge in the jaw. So what to do? Remove the teeth and then put the implants or put the removable prosthesis? No, we have to see the macro aesthetic of the face. So that's what I did. And I increased the 11 and 41. I obtain a position, I give it to the lab, and the lab make a removable prosthesis from the upper jaw and something in composite for the lower jaw. And I give him a new position, and that's after a week, the extraction. The patient was very happy, and then something opened in the mind of the patient, and she's asked me, "Doctor, I feel so beautiful, I feel so good. Maybe I can change it for removable to fix." And in my clinic are the patient propose me to put the implants. And so when you have a good natural removal prosthesis, it's very easy to change it in Toronto Bridge. And that's what I did to her. And I changed it in Toronto Bridge. Like this. But everything starts from this repositioning. And that's the final results. The final results. So let me change in the second part on the digital. So I introduce you something about the digital, the analog way. So now let's talk about digital. So we understand that we have a protocol very, very common in the world. I already show you the functional is the with the jig and the aesthetic and phonetic test, and the postural test that here I will not speak you, but there is also Professor Di Rocca in this big conference. He will tell you more than me. So how does it work? We increase the 11 and 41 at the standard position. Then we make the aesthetic and phonetic test. A, E, F, and S. We obtain the contact as a jig. We found the neuromuscular position. We lock it and we rebuild the 2.1. And then we make the postural test. So I'm speaking about this patient. That's the patient I want to, I expect arrive to me. And that is what is happening. That not just to me, to a lot of colleagues. And I will show you how many colleagues are making prosthesis in this difficult case. Because we are a little bit scared when we have this patient, because we don't know how to do it. Just an impression and say to the lab, please make a wax up. We have a protocol, very easy. The results are always incredible, always perfect. So the question is, can we do it with digital flow? Yes, we can do it, and I will show you. Arrive to me this patient, and I ask you what to do in this mouth. She lose vertical dimension. Well, I think a lot. So in the first section, with the new opportunity that we have, I scan the mouth and I scan the face. Okay? So I send everything to my lab, and the lab match, and then I connect with them with TeamViewer, and they have not just the mouth of the patient, they have also the face. And I say them, well, for me, these 11 and 41 and 2.1 are a little bit longer because I have the face. They can make an ecstatic wax up. So I give all the indication in the way I want the vertical dimension. Without this, they will do it in digital, the same of analog, but I don't want that. What are you looking now? So they produce me in PMMA this small crown. I put on the patient, on the face of the patient, in the mouth of the patient, and I make my aesthetic and phonetic test. Let's think together how they look. A little bit longer. So for me, they are longer, aesthetic test, and I make them short. Then we have the aesthetic phonetic test. In the phonetic text, word with S, the two incisor doesn't have to touch. Let's see. Yes, they touch. So I put a paper, I see where they touch, I remove it, and I make it again. Perfect. They don't touch. They don't touch, so I expect what? I wait. I obtain the jig and I wait the drum test. So the jaw doesn't have to be strong. The muscle must be relaxed in this way. Okay, so she was not relaxed. I wait another 5 minutes. Perfect. So it was perfect. Then I fix them. I use Futardi Kettenbach, but you can use any material. I scan the position. I scan the position. The lab has the reference, but what we needed this. We needed Ithaca. We are taking adaptation dynamic, the dynamic in adaptation of the patient is the only we can take it. This is Ithaca. In 7 minutes, I take the individual dynamic of the patient. So go everything to the lab, and the lab make this provisional, how to put them in position with a guide, something like implant. So I prepare, we bopped the teeth. I have a guide, they go in position. For the upper jaw, and same for the lower jaw. And how was the result? I was expecting a great result, but well, the patient closed like that. So what to do? To transform the work of the lab in this way? No, I make a jig. We are looking for a position like that the muscle like, and I wait the relaxing of the muscle, and I use the 200 micron occlusal paper, because then I will see where is the problem, and was just one problem. And in 1 minute, I was just in the contact of the provisional. So let's see how they eat, how she eat. So she has an impact here. No good. We have to open a little bit. Okay, don't forget, we open a little bit the bite. Then we wait 2 weeks. And we asked them, how do you feel it? Someone told me you increased too much the vertical dimension. How to understand that I really increased the vertical dimension too much? Not at all. With asking, matching a younger photo. This is the best of the best for the patient. We reply what the situation she has before the destruction. So we will wait 3 weeks. We will ask, how do you feel? Okay, everything is perfect. So we scan, and then we make another Ithaca, and we will see how was the movement, the dynamic of the patient before and after. Also, you see that's the how we see the computer, and we see the reports. This is wonderful. We can match. We can see before the movement and after. See when she in the blue was the first dynamic of the patient, and see now. Now she has a really physiologic dynamic. Also, this is a check that the doctor in postology I have in my clinic. We make ray face. Ray face in 1 minute. We scan the face. Everything go to the lab. Lab make a wax up, aesthetic wax up, dynamic wax up. Do you remember the patient with the provisional say, I impacted the front, so I was opening the bite? A lab never leave you final prosthesis with the open bite. But this is the nature of the patient. And then I ask them, and you will see, this is simple zirconia, monolithic, three-bridge upper and three-bridge lower. But before receive the zirconia, they go on Arthur. On this robot articulator, move with the dynamic of the patient. So what we expect? We expect that when we put the prosthesis in the mouth, they are perfect. And they was perfect, and we finalize glazing, just glazing the bridge. You will see something interesting, that we have a small open bite on one side of the patient, on the left side of the patient. Yes, left side. You see, this is the small open bite. So this is the what I want to obtain to my patient, that during the natural movement of the chewing, everything was perfect. So let's see the final results with some picture, and let's call again the patient after 1 month and see that we try to copy what nature give her before the destruction, the erosion of the teeth of the patient. So someone, and we call this this protocol, I call it the vertical box technique. Someone asked me, but are you sure that this patient feel good? Okay, as I know, I make the doctor and I make an orthopedic checking after a few months. Everything is okay. Prolonged opening, Enfield, left and right side. We check the pterygoidate on the both side, cotton roll, masseterium, temporal, sternocleids, everything work okay. She doesn't have pain, and then we already ask magnetic resonance to check the TMD, the TMJ. And if you see, it's perfect, no problem, no pathology. This patient feels good. And then also we make some posturological test, and the mouth of the patient speak perfect with the rest of the body. We found the perfect equilibrium in the patient, in this patient. So this is a technique, the vertical box technique. Someone say, yes, it worked just to you. Like in this patient, they are patient of me. It's always the same. This is the results, just with provisional. Or for example, here they call, I work in many different clinics in Italy. They call me and say, how we can put implants? We don't have the prosthetic space. And I propose them to make vertical box with the Ithaca, with the scan face, with the intraoral scanner. And the lab produced to me. First, they make aesthetics and dynamic wax up. like you see, and they produce this rebalance. This is a very smart way to check what should be the results at the end of our rehabilitation. And also the patient know before start how he will feel at the end. It is removable, very easy, no risk. And the patient after a week call and they say, yes, I want the results. Like in this way, how to start? Just with a wax up of the lab, vertical box. Vertical box, with all the technology we have, the lab make an aesthetic and dynamic wax up, easy, rebalance, test in the mouth of the patient, and the patient like it. They say, yes, doctor, this is what I want. I'm sure, and he is sure that the result will be perfect. Okay. Someone say, okay, but this vertical box just work in your hands. No, this is from Sicily. You see, for example, in this case, rebalance. The patient know before to start how she will look and she will feel. Okay, so they say, okay, another doctor from Pescara, Central America, a big friend of mine, with vertical box, he obtained the results very easy. Also from Sardinia, Dr. Minniti, big oral surgeon, he used all the technology. And he say, but was too easy. And then the patient called them. They say, I like how I look now, and I feel more comfortable, more comfortable. And every day, I receive patient, not done by me, but by colleagues in this way with the vertical box. The results are all perfect, always, always the same, always the same. And this is from Sicily, Studio Sant'Agati. They are rebalanced. And here there is a small video where she say that the patient make a test of 3 weeks, and the patient is happy, he feel comfortable, he didn't broke the rebalance like this. Also here from Torino, he told me how I start in this patient. Then he was making my course, and he learned a vertical box, and that's the results he obtained. This is rebalance, removable. And he said, but this is perfect. And the patient also say, yes, I want my mouth like that. So it will be very, very, very easy, very easy. And every day, I receive direct in my clinic or through other colleagues are making vertical box this nice rehabilitation in situation very, very difficult and complicated in the past. So you can't go back and change the beginning, but you can start where you are and change the ending. And who cannot change their minds cannot change anything. Thank you very much. If there are some questions, I'm here.